Hello everyone, my name is Viviana Barboza and I am here to tell you about my clinical scholarly project. For a little over 2 years now, I have worked in the PACU and short stay departments, and from what I have seen and done some research on, I have decided to focus my project on post-op instructions given to patients following surgeries. In the hospital I am planning on implementing this project in, they currently provide discharge instructions to patients following a surgery in the discharge phase, which follows the post-anesthesia phase where patients are recovering from anesthesia and are also given narcotics. This can become a problem when giving instructions to patients since they may not remember information given to them or understand the instructions clearly. I plan to implement a project where patients are reached out prior to their procedure, preferably a week in advance, and are given instructions about how to care for surgical incisions, what to expect during the recovery phase, and what signs and symptoms to look for during recovery. I believe this information given to patients in advance and making sure they understand the instructions will not only make the patient feel comfortable for caring for themselves following a procedure, but I believe it will also have a decrease on readmission rates for patients discharged following surgery. The conceptual framework for this project is based off of two theoretical foundation models that I believe are crucial and important for this project. Peter Drucker's model of behavioral theory emphasizes change, which I believe will be very important in this project. His model focuses on the fact that change is unavoidable and that one must prepare and address change, or that an organization will not sustain. As nurse practitioners helping and leading the healthcare world, we must be able to take on the role of a change leader who knows how to look for change, can find the right change, and understand the effects of change. Being educated and skilled in the ability to take on the position of a leader, and in order to find a balance in the organization we will provide care in, we must be able to acknowledge when change is needed and to properly establish that change. Once that change has been made, it must be carried on since change and continuity are thus poles rather than opposites. This theory is the foundation for the change that I believe needs to be implemented in order to improve quality of care while benefiting the patient as well as hospitals. The second model is the relationship-based care model, which I will refer to as the RBC model. And it was created with the patient and family at the center of the 6 core components that make up this model, and it was concluded that relationships are central to healthcare. We experience the essence of care in the moment when one human being connects to another. When compassion and care are conveyed through touch, through a kind act, through competent clinical interventions, or through listening and seeking to understand the other's experience, a healing relationship is created. This is the heart of the RBC model. In order for one in an advanced practice nursing role to deliver quality care and improve the health outcome of a patient, a bond must be formed to be the core of the healing environment. The nurse-to-patient relationship is the key relationship in this model, and the second is the nurse-to-self relationship, which is often viewed as selfish when in reality it is critical in this model. Caring for oneself is a healthful endeavor that cannot be foregone. The third relationship essential to this model is the nurse-to-healthcare system, which functions best when the first two relationships are strong and significant. The alliance of these 3 relationships allow for nursing leaders to provide optimal healthcare to their patients. The stakeholders that will be benefited by the implementation of this project are the administrative team of the hospital, who are in control of finances, personnel, medical policies, and community relations. The director of perioperative services, who controls the clinical aspect, is also a stakeholder who would benefit from this project. Another important stakeholder that would be of great benefit from this project would be the patient and families who are the center of a hospital's goals. In 2001, the Institute of Medicine released a report titled Crossing the Quality Chasm, A New Health System for the 21st Century. Included in this report were potential reasons for readmissions of patients following their previous hospital stay. Some of the identified reasons were poor patient discharge instructions, patients were not provided information regarding medications, patients did not know of warning signs to assess if their condition was worsening, and patients did not receive contact information for questions. These reasons all point to a problem with transition care. Reading these reasons and working in a surgery unit, I decided to focus on the aspect of discharge instructions given to patients. With advancements in technology, surgeries today are done via the laparoscopic technique, and even following some large procedures, patients may go home the day of surgery. The process in place now is to give patients post-operative discharge instructions after the recovery phase, which can be concerning since patients receive anesthesia and narcotics in the recovery phase. While improving quality of care of patients is a main goal of the healthcare system, it is also a goal to provide this care within an affordable manner. Once it was recognized that readmission was a problem of the healthcare system, more research was conducted and found that about 2 million patients return to the hospital each year, which costs Medicare about $26 billion. According to the National Health Statistics Report, preventable hospital readmissions within 30 days of discharge roughly account for 18% of readmissions, which results in $17 billion in Medicare expenditures each year. The Affordable Care Act has implemented a program to address this problem of readmission rates known as the Hospital Readmissions Reduction Program. To avoid hospital readmissions, the program penalizes hospitals that have higher rates of Medicare readmissions, which is an incentive that drives hospitals to improve and monitor the care that is actually being delivered to patients. Hospitals can lose up to 3% of Medicare payments for the patients that are readmitted within 30 days of a previous hospitalization. The goal of this program is to decrease readmission to hospitals, and this can be prevented by implementing changes in hospital care that improves discharge processes and ensures patients are prepared for this transition of care. Healthcare professionals must be involved in the patient's care from start to finish, which involves the time a patient transitions from the hospital to their home, where they become the sole caretaker of themselves with or without the help of family. The management of care at home greatly depends on the hospital's process of discharge and how information is given to patients, with many factors involved that contribute to patients being rehospitalized. I plan to implement a process where nurses in advance, such as 1 week prior, call patients and give them discharge instructions beforehand and explain what to expect and how they should care for incisions, drains, etc. Information will also be given about what signs and symptoms to look for and to seek medical attention as soon as possible rather than waiting for symptoms to worsen. Patients will also be given printed out information that is specific to their procedure so they'd have something to refer back to. Having seen firsthand the gap of knowledge patients are faced with, I want to work on a scholarly project that addresses post-operative teaching prior to the surgery. With the RBC model as my primary model and the basis for my practice, I believe discharge instructions could be a responsibility of the preoperative team where they are able to form a trusting relationship with their patients prior to their surgery and address any concerns and provide explanations when they are not under the influence of anesthesia and narcotic medications. In order to facilitate this change, I believe the administrative team should incorporate an educational source for nurses to print out pamphlets on surgeries that patients may have, and those instructions should also be available in additional languages. The educational needs to the stakeholders of patients and families is that they should be comfortable enough to want to ask questions and that they should not wait to get answers. I also believe patients and families would also benefit from demonstrations from the nurses and provide return demonstrations where nurses can assess if patients and families truly understand the instructions that were given to them. Lastly, patients and families should be given pictures so that they can refer back to what to avoid or how to do something properly. As nurses, it has become second nature to care for patients, but we must realize that some of these patients do not have that second nature and must be fully educated on how to care for themselves following surgery. I believe my scholarly project will have a great impact on patients and will result in less readmissions when patients are knowledgeable in the surgeries they are having and how to respond to signs and symptoms. Thank you.